All right, we're going to be doing threats to fluid balance. It is chapter 16 in the 10th edition of Lewis, and it is chapter 22 in Juan, which is your pediatric book, also the 10th edition. So basically, we have our body wants to create or maintain homeostasis, and that is that equilibrium. So when we're talking about fluid and electrolytes, we're creating a homeostasis or an equilibrium of electrolytes and fluids and all that balance in our body. And many organs have a role in helping maintain that homeostasis. So we've got the kidneys. The kidneys maintain their role because they help us excrete things. Well, they excrete waste, they excrete body fluid, they excrete electrolytes, and they help maintain that balance. The lungs help maintain homeostasis. With our respiratory rate, we lose about 300 cc's of fluid a day just from our respiratory system. So like days like today where I am lecturing a lot and talking a lot, I drink like 7 gallons of water because the more I talk, the more I am spewing out at you all, right? More fluid I'm losing, so I get thirstier. So we have to think about that when we think about things like an increased respiratory rate. That's going to increase their fluid demands. So if you have a patient that has a really high respiratory rate, you might want to make sure that they're getting enough fluids. Heart. It's going to help pump blood to perfuse those kidneys that are maintaining that balance. If you have a low blood pressure, what happens to our heart rate? It increases, right? Gets tachycardic to try to compensate and make sure that our cardiac output is maintained. Your adrenal glands secrete aldosterone, and that aldosterone basically retains sodium in water. So when it secretes it, we're retaining water. When it holds aldosterone back, we let go of water and sodium. And it's constantly kind of holding it and excreting it to make that balance happen. But if something's wrong with the adrenal gland and we really should be excreting it to retain water and the kidneys don't for whatever reason, then we can get dehydrated. Parathyroid regulates calcium and phosphorus. And the pituitary secretes ADH, which also helps with retaining water. All right. So there are going to be factors that threaten this fluid balance. They can be physiological. So organ function itself, if any of those organs that we just talked about malfunction, we're going to have an imbalance of fluid and electrolytes. If there's any kind of inflammatory process or infectious, like if we have diarrhea or UTI, that's going to affect our fluid electrolyte balance. Children in general are, like we talked about, we said, the infants, we were talking about infants and how they're just different. Children in general, they have a higher body surface area, so we have insensible losses from our skin. And if they have a bigger body surface area, they're more likely to lose insensible losses. They have a higher metabolic rate, so they metabolize waste faster. So they're creating more waste that they need to excrete faster. So if something's wrong with the kidneys, they can build up waste faster. They have a higher respiratory rate, so increased water loss. Their kidneys are immature, so they're already metabolizing really high, and then their kidneys aren't functioning great because they're just not mature enough yet. So sometimes we have to be careful about that balance. And they have higher fluid volume requirements. They have little reserve. Kids will compensate, and then crump, all right? Adults, you'll kind of see that steady decline. You know that something bad is happening. But when a kid is sick, they will do okay, but because they have little reserve, their compensatory mechanisms aren't great, When they crash hard. Psychologically, there are things that threaten fluid balance. In general, if you're anxious, just you're not a big water drinker, or you drink water all the time, or sociocultural things like pica. Have you guys heard of pica? Eating things like that that aren't food. Kids who eat sand or dirt, or who chomp on ice cubes all the time. So when we look at this baby, the little baby's in a radiant warmer or phototherapy. What would we worry about with his fluid electrolytes? Huh? Dehydration, because he's got a radiant warmer on him. His body surface area is higher, so he's losing more fluid out of his skin, and if we aren't hydrating him more, so he's going to need more fluids than somebody not under phototherapy. So he's going to get dehydrated fast. So we've got to think about these things when we are looking at our patients. We already kind of talked about all this. It's all there written for you. If they're febrile, they have a respiratory infection, they're vomiting, diarrhea. Obviously, those are all risk factors that are going to put them at higher risk for developing dehydration. The big thing that we are going to do, the big first thing that we need to do is get a good history. Because a lot of times when you guys are taking tests and your thought process, you are, they ask you, they're like, this is your patient came in, and what are you going to do? And you want to go ahead and initiate an intervention. Well, that's great. If you have someone bleeding, and they're bleeding, and you're like, okay, that we need to give them blood because their hemoglobin's low, but you never stop the bleed itself, eventually you're not going to be able to catch up, right? So a lot of times we have to figure out what the cause is. Because if we don't treat the cause, we're going to continue to have the problem. And you guys want to jump right to that intervention before saying, oh, wait a minute, what's causing it? Because I need to fix that problem, and then I can catch up. So we need to find out why they're becoming dehydrated. Fix it if we can. Do they have any other health problems? Do they have any chronic diseases like we have a lot. We're going to talk about some different GI diseases, like Crohn's, that might put them at risk. So is there something that's going on with them? Have they been exposed to any recent infections? This is really important because if they've had any sick contacts that's causing the issue, especially if it's vomiting or diarrhea, we want to isolate them because we don't want it to spread. Physical exam is next. We want to look at their general condition. Do they look sick? Did the parents say, oh, they threw up 3 times, but the kid's like, hey, running around and crazy? Or did the parents say he threw up once and the kid's like, sunken eyes, looking horrible? So what do they look like? What is their mental state? This is probably one of the first clues. We hear this all the time, that changes in mental state are one of our first indicators that something's going wrong. It's why it's so important that when you guys are out in clinical, one of the first things you do is go do a quick 60-second situational on all your patients. Walk in the room, say good morning, say I'm the nurse going to be taking care of you, kind of look around the room, see what's going on. Because if your patient was totally with it this morning, was like, good morning, hi, Nancy, and then an hour later is like, what is your name? I don't remember. That's going to be a first clue that something's not quite right, okay? Kids tend to get irritable. They don't really have changes in their mental state, but they might be a little bit more irritable. The adults, your elderly will get confused. They can have decreased level of consciousness, but that's more of a later sign. But your elderly, one of the first things they do, especially like even with infections like a UTI, how do they normally present? With confusion, right? Vital signs. We check temperature because if they've got a fever, some infectious process. they're at higher risk. Pulse, blood pressure. We'll check their respirations. Blood pressure is going to be one of the most important factors that we monitor for adults. All right. We can really see a fluid status change for adults. Their blood pressure might drop a little bit lower. For kids, remember, they're going to compensate for a long time. They're not for a long time. They're going to compensate for a bit, and then they're just going to crash. So you're not going to see big changes in their blood pressure. Adult, you might see, oh, it was 120 over, 85, and now it's 115 over 80 and 110. You're going to see some changes, but a kid's going to kind of hold steady and then crash. So we're going to monitor their blood pressure, especially for adults. For kids, we're going to look at weights. That's how we're going to know a big difference with kids. And when we talk about the extent of dehydration, we'll calculate how the percentage of dehydration based on their weight. So, and kids we're weighing all the time, right? Especially infants. Who has kids in here? Okay, so if you've had kids, you have during their infant period, you bring them in at birth, at 4 weeks, at 2 months, at 4 months, at 6 months, at 9 months, at a year. Like, you are constantly in the pediatrician's office. You know their weight. It gets a little harder when they get older, but especially when they're younger, weight is going to be a really good indicator on how dehydrated they are. We can look at their cap refill, although this tends to be a later sign. Obviously, the cap refill will be delayed, greater than 3 seconds. Kids, we're looking at their tears. If they're sitting there screaming, but no tears are coming down, they're probably dehydrated. All right? It's like the most pitiful little thing you've ever seen is this kid just screaming, crying, but no tears coming out. Going to check their fontanelle. So we talked about that soft spot on the top of the head. It should be nice and flat. If it's sunken, it's a good indication that they're dehydrated. Their mucous membranes, obviously that's a very early sign when your mouth is dry. We can look at their skin and how elastic it is. But remember, for our adults, do they have the greatest, most elastic skin? Especially the elderly? No. So it is not a great assessment tool. For kids, obviously, we're much more they have more elastic skin. But we tend to check their bellies. Those nice squishy bellies, that's where you would kind of see if they're... And then obviously their I's and O's, what's their intake, what's their output. And why I and O's are great. Remember, we have all those other insensible losses, just typical losses from the skin, respiratory rate. So when we look at I's and O's, we're not taking into account those other insensible losses. So if you're like, oh, well, they threw up 300, but they took 300. But if that kid's sitting there going, and like with a fever, they might be balanced by their I's and O's, but they're not balanced because they're losing more through insensible losses. So we can't just look at those I's and O's. All right. So there's a lot of diagnostic tools that we can get to kind of confirm or help us along with the dehydration. We're going to get a CBC because we want to look at the crit, the hematocrit. So hematocrit, if you remember, it's the number of red blood cells in the volume of blood. So it's not that, and it's going to be elevated. And it's not going to be elevated because you have more red blood cells. It's elevated because your volume is low. So if you've got red blood cells to volume and they're normal, your volume goes down, what happens to your crit? It's technically up, right? Even though there's been no change in the amount of red blood cells, because you've lost volume, it appears as though it's higher. So your crit's going to be higher. Your UA, we're going to look at the osmolality of it. We're going to look at electrolytes like sodium and potassium. And we're going to talk about dehydration, types of dehydration. And sodium is going to be your driving factor of what type of dehydration you have. Potassium is something we monitor closely, especially if they're not peeing, we don't give K, right? No pee, no K. You've heard that before? No? Okay, now you have. So if they're not peeing, potassium is excreted in your urine. So if they're not peeing, they're not excreting that potassium. And so it's building up in their system. So we want to make sure that when we're rehydrating them, we are not giving them fluids with potassium in them, because increased levels of potassium cause what? Yeah, cardiac dysrhythmias. It's all coming back to you now, right? No? It will. You see how we're going to start pulling all these pieces together? All right, stool, we're going to look at, if we need to get a stool sample, if it's infectious, if they're having any malabsorption problems. Look at BUN and creatinine, that's an indicator of kidney function. So obviously it's going to be elevated. Your serum osmolality, that's different than your urine. So, but it's going to be lower because it's going to be concentrated. And then when we want to look at the extent of dehydration, because when we look at the extent of dehydration, it guides us to how we're going to treat, okay? So we are going to we measure the extent by the percentage of the last measure in weight. So we take the original weight and we minus the current weight and divide it by the original weight. So for example, if the kid is 12 kilos originally, and since they've been throwing up or since they've had rotavirus and had diarrhea, they're now 11 kilos. You would do 12 minus 11 over 12. So original minus the current over the original. So 1 over 12 is 0.08, which is 8%. Everybody follows that? Okay. When we are looking at extent of dehydration, anything less than 5% is considered mild dehydration. Moderate is 5 to 10%, and severe is greater than 10%. So where does this kid fall? Moderate. Okay. So mild less than 5, moderate 5 to 10, severe greater than 10. That's going to help us because when we're looking at interventions, a lot of people, when kids are throwing up or kids have diarrhea, the first thing they want to do is stick an IV in them and give them fluids. And that is honestly not the best way to rehydrate someone. The best way to rehydrate someone is oral rehydration therapy, ORT. All right? We want them to drink, okay? And if they are mild or moderately dehydrated, that's what we're going to try to do first, is oral rehydration therapy. Obviously, we're going to find out what the cause is. If it's because they're throwing up, we might give them an antiemetic. If it's because it's diarrhea, we kind of let diarrhea run its course. We'll talk about that in a second. But we might just have to be more aggressive with our treatments. If it's other reasons like DKA, we need to treat DKA. If it's because they're not taking enough, we need to increase what they're taking. If it's because of a blood loss, we may need to give some blood transfusion. So we got to find out what the cause is and start treating it. And then we're going to monitor those vital signs, their I's and O's, their weights. If they're vomiting, and that's the reason that they're dehydrated, we're going to go ahead and hold their diet until they're drinking well enough. And ORT, like I said, that oral rehydration therapy, that is the treatment of choice for mild to moderate dehydration. We want them to drink. The only time we use IV fluids if it's a severe issue. And we will isolate them if it's indicated. So if we think it's like an infectious diarrhea or infectious vomiting, we go ahead and isolate. I love when I've been, because I work in the ER, and I love like after I've been in the room and I've examined the patient and like been in the kid's face, because I tend to be very like, after I've done all of that and like loved on the kid and kissed them and held them and rocked them and examined them and did everything, and then I walk out and they're like, oh, that kid's on precautions. I'm like, awesome. So communicate that really well, with people so that we don't spread disease. All right. Why don't we want to give someone with vomiting and diarrhea? Like when we talk about oral rehydration therapy, what we're talking about is things like Pedialyte, stuff with a little bit of electrolytes in it, okay? We don't want just free water. We're going to talk about that in a little bit, necessarily. We want something with a little oomph in it. But why aren't we going to give them anything like apple juice or sodas? Yep, the sugar. So what happens with the sugar? What does it do?
They give the GI system.
So GI is, it pulls water, right? Sugar pulls water. So if you're giving them sugar, it's going to pull more water out of them, and it can actually increase diarrhea and make things worse. So it's really important because even you, like when you have thrown up, you just you're very particular on what you want to eat, right? I got sick back in March. I got a random GI bug, and I had eaten blueberries, and I puked my brains up with the blueberries, and I cannot eat a blueberry right now to save my life. So I get it. It gets very sensitive when you don't when you've gotten sick and you don't want to have something, and you want to entice the children to eat and drink something. And again, focusing on that drinking first. But you don't want to just give them juices and sodas because that could actually make the problem worse because of the sugar content. So we recommend Pedialyte, but Pedialyte tastes like doo-doo brown, okay? If you've ever had it, it is not enjoyable. I was going to say some of the flavors are better. I can tolerate the popsicles better than the straight up, but the straight up clear Pedialyte is awful. But it's got the electrolytes that they need in it. If they really won't take Pedialyte, we can do something like a Gatorade, but make sure that it's watered down Gatorade, because Gatorade still, or the G2, like the sugar-free Gatorade, because then they get the electrolytes without the sugar content. All right. So we're going to look at different types of solutions. So I'm going to kind of do a little quick, you should already know this. Osmosis is basically where fluid flows from an area of lower concentration of molecules to a higher concentration. This is a concept from previous levels anatomy. All right. We have crystalloids and colloids. Crystalloids have water and molecules that can pass through membranes. Colloids are like albumin. They have larger molecules that don't pass through those membranes. And I'm going to cross that out on your, cross out the sodium. You don't need that for this part. So when we're talking about isotonic solutions, we are saying that the solutes in the cell equals the solutes in the solution. Okay, so you can see right here, the blue is the water, okay? The red is the solutes. So you can see that there are 4 solutes outside the cell, and there are 4 solutes inside the cell. All right, this cell has a semi-permeable membrane, meaning that it allows water to move in and out of the cell, but it doesn't allow solutes to move in and out of the cell. And this cell is basically immersed in a solution right here, okay? It's obviously exaggerated for teaching purposes, all right? So in an isotonic solution, when I give the solution, which is out here, that solution matches the same content into the cell. By theory of osmosis, is there any water being passed back and forth? Nope, it's the same. All right? With that, when I give that type of fluid, what is it expanding? It's expanding that extracellular volume. It does nothing to the cell itself. It expands just the volume in the vessel, right? So It's only going to expand extracellular volume or intravascular. It's the same thing. Inside the vessel. It has no effect on the cell itself, no effect on the intracellular because there's no osmosis happening, right? There's no water moving in and out of this cell. So solution is used when we have volume deficit, when we just need to expand that intravascular volume, like you have a large blood loss. Yeah, we're going to talk about it. So whether they're hypovolemic, hypotensive, this is a good solution we use, but we have to be careful because it can very easily cause fluid overload. So we're going to be doing what? What is some of our key assessment things that we're going to be listening for? Crackles, right? Because that's going to be our first sign and symptom. Adults don't really show fluid overload. They don't get puffy, they don't get edema really, but they will sound wet. And so we need to know that when we're giving fluids, isotonic fluids like normal saline and LR, that we could, because we're giving it to them for low volume, that when we're giving those fluids, we really need to make sure our assessment skills are on point, especially when it comes to listening to them and listening to their lungs. You don't need that. You can cross that out, the sodium level. Hypotonic is when the solutes are less concentrated than the cell. So there's more water than electrolytes. So you can see here inside your cell, you can see, a bunch of solutes to water, but outside the fluid you gave them was hypotonic. So that fluid right there is hypotonic because it has less solutes than it does water. So where does water move? Which direction? Into or out of the cell? Into the cell, right? Because remember, we're all about homeostasis. We're all about a balance. And right now, it's going to pull water into the cell to balance it out. Because the less water I have, it wants to balance the water to the solutes. So water is going to be pulled into the cell. What happens to our cell? It expands. So we have to be very careful because what happens if it expands too much? It's going to burst, right? And this is when we talk about cerebral edema, that's what we're talking about. So it's going to pull water into that cell. And it's used when as a maintenance fluid, it rehydrates. But we have to be very careful for cerebral edema. So, if I know that I'm giving an isotonic solution, what's one of my key assessments that I'm going to be looking for? Mental status, right? Because I know that they're at risk for cerebral edema. So if I have any change in my mental status, that's going to be a red flag. And for me as the nurse to be like, hey, doc, I've got him on this hypotonic solution. We've have him going at 100 cc's an hour. He's acting a little confused. I'm going to go ahead and decrease the rate. Let's pull some labs and see where his sodium's at. Okay? You see now where we're taking this information and we're not just knowing it, but we're applying it? This is where we're trying to get to, okay? So examples are half normal saline, D5W. Now, D5W is the one that people always get confused about because D5W is dextrose, 5% dextrose in water. And it is isotonic in the bag. But when it gets introduced to the body, that 5% dextrose is a little bit and it gets metabolized up and it just becomes free water. So free water does not have any solutes. It's why when they get sick and they're vomiting and diarrhea, we just don't want to give free volume for this reason right here. That's why we want to try to give something like a Gatorade that has some solutes in it because we want to expand volume, not push fluid into the cell. Okay? when we talk about normal saline, everyone knows normal saline is, if you didn't know, that's okay, that's why we're talking about it, is 0.9% sodium chloride. Okay? LR has a little bit different, like magnesium, and you don't need to know all of that. LR is essentially normal saline. But normal saline is 0.9% sodium chloride. So anything less than 0.9% is going to be a hypotonic solution. Anything added or more than 0.9% is going to be hypertonic. So half normal saline is 0.45% normal saline. It has less sodium chloride, so it has more water than the sodium chloride molecules. Is that making sense? If not, stop me. The last is hypertonic, and again, you don't need that sodium level there. And this is where the solutes are more concentrated than the cells. So there's more electrolytes in the solution than water molecules. So if we look at it, you can see right here, inside the cell, there's only 2 solutes. But outside the cell, there's a ton of solutes. So where is water going to go? Out of the cell, okay? It's going to, water follow solutes. So just always think about that. Wherever the solutes are, that's where the water is going to go. So if there's an even amount, it's not going to go anywhere. If there's more solutes on the outside, water's going to leave that cell, okay? If water starts leaving that cell, what happens? It starts to shrivel up. When we do that, it shrinks the cells and it puts them at high risk for seizures. So if I know that I have a patient on a hypertonic solution, again, what is going to be one of my first things that I'm going to be assessing for this patient? Mental status. You know, we could put them on seizure precautions, making sure that all the bed rails are up, that we're not leaving them alone, that we have someone monitoring them, right? Because I know that they're at high risk for this. And as soon as I notice something, I'm going to be calling the doc, stopping the solution, getting, lab work. So it pulls water out of the cell. It's used to treat hypovolemia and hyponatremia. But again, if it's pulling water out of the cell, we are again at risk for also overload. So we're at risk for seizures and still overload because all the water that was inside the cell is being pulled into the intravascular space, plus we're giving them fluid in that intravascular space. So we're also going to be listening for crackles on these patients as well. Examples are D5.5 normal saline. So that's, and because you're adding to it. D10. So I know D5 was hypotonic because the glucose got absorbed. But in D10, there's enough glucose that it doesn't all get absorbed. So it's hypertonic. D5 normal saline, 3%. No, it's not going to let me. So D5 normal saline is one, and also 3% normal saline. And again, we got to be careful. If your patient's not peeing, we have to make sure that there's no potassium in these solutions. And this is on page 293 in your Lewis textbook. It's table 1617, and it discusses the different types of solutions.
You need to know this. This is very important.
All right. So now that we know types of solutions, when we can figure out the type of dehydration they have, then we know what type of solution to give them. And that's what you would need to know, all right? So Now you want to know the sodium levels, okay? So when we talk about isotonic dehydration, their sodium level is essentially normal, right? And I think your Lewis book has a little bit off on this. We will make it obvious, that it is ice within normal or severely hypertonic or severely hypotonic dehydration. But in general, normal sodium is what? 135 to 145, right? So if I'm in the 130 to 150 range, I'm essentially within normal limits for my sodium, right? So basically what that means is I have lost electrolytes and water equally. And I'm going to be giving you examples of each of these. And remember, there's some gray area, okay? Essentially a blood loss can cause an isotonic, a hypotonic, a dehydration. So don't get too focused on, every single little etiology. But if they have severe vomiting, diarrhea, they have profuse bleeding, those two are really the big ones for isotonic, because they're pooping out or they're vomiting both fluid and electrolytes. Or when they bleed, they're bleeding out everything, right? So we know we have an isotonic dehydration. There is no water moving in or out of the cell. So we have a volume loss. What kind of solution do we want to give them? Say it louder. Isotonic, right? Because all we want to do is expand the volume. We don't want to move solutes or water in and out of the cell. We just need to expand the volume because they've lost volume. So we're going to give them an isotonic solution. When they have hypotonic dehydration, the sodium's less than 130. Then you have lost more electrolytes than water. The electrolyte deficit is greater than water. So when that happens, think about it. I've lost electrolytes out of my extracellular space. So what's this? There's now a concentration of solutes inside my cell. So I have more solutes inside my cell than outside, right? So where is water going to be pulling towards? Inside the cell. We want to stop that, right? So if that's the problem, we want to stop that from happening. Then what kind of solution do we want to give? Hypertonic. Why? Yes, it does say it on your paper, so that is why you would do it. Thank you for that honest answer. But if you think about it, right now, inside that cell, you have a bunch of solutes, and water is coming in because you've lost more electrolytes, right? So we want to reestablish electrolytes in the intravascular space or extracellular space so that we can maintain balance, so that water won't be shifting into the cell, all right? So muscle damage causes it, burns, but the mannitol, a drug, can cause hypotonic because it's just trying to get fluid off of you. It's trying to get electrolytes to follow for the fluid. But you're going to treat with a hypertonic solution. So if it's a hypotonic dehydration, you want to treat with a hypertonic solution. Now, are we going to say now, your patient has a hypotonic dehydration. What are you going to do? A, isotonic. B, hypertonic. No. We're going to start seeing things like your patient comes in, complaints of, complaints of vomiting and diarrhea for the last 3 days. The sodium level is this. What solution are you going to give? And it's going to list normal saline, 3%, sodium half normal saline, and then you have to pick which is the right answer, okay? You have got to know it is this type of dehydration, I need this type of fluid, And these are the fluids that are examples of that. Hypertonic is sodium greater than 150. I think Lewis says 155. That's where I was saying there might be a little difference. But so there is water loss that is greater than electrolyte loss. So now, inside my cell, I have solutes in water. And now, outside my cell, I've lost a bunch of water, but I still have electrolytes floating around. So my electrolytes or my molecules are higher on the outside of the cell. Where is water going to go? Out of the cell, right? Because it's going to go towards that. What happens when it goes out of the cell? What am I at risk for? Cells are shrinking, which causes seizures, right? So my patient's at risk for seizures. I don't want to give them, if I give them a hypertonic solution, when they have a hypertonic dehydration, what's going to happen? I'm going to do what? Pour more water out of that cell. I'm going to basically just say, here, I'm giving you something to seize, okay? Have a nice day. We don't want to do that. So we want to balance it out. So we need to give them a solution that's higher in water content so that we can balance out those electrolytes. So what kind of solution are we going to give them? Hypotonic, right? So we want to give them a hypotonic solution. We want to basically create that homeostasis and stop that osmotic forces from happening. And we basically have to do the opposite. So if I've got a hypotonic dehydration, I want to give a hypertonic solution to balance it.
Can I throw a point in? Maybe I am finished.
And I think that I already said this is in your WAN book. So the description of this is in your WAN book. It's on page 693. So if you want to go over it a little bit more to make sure you've got it down. All right, does that make sense to everybody? Mm-hmm. You see why it's kind of important to understand what the solutions are, why they do what they do, and then understand what type of dehydration you have so that you make sure you give the right solution. All right, so we've already kind of, again, your PowerPoints have what we've talked about. I just put them in a different format so you can see them there, clinical manifestations. You should know the different clinical manifestations of hypo and hypernatremia and hypo and hyperkalemia. Basically, if you have too much or too little potassium, you're going to have a cardiac type of dysrhythmia, some kind of cardiac problem. Your sodium is related to your neuro system. So if you have a sodium issue, you typically have neurotype symptoms. That's the easiest way to think about it. Now, that's a very general way, but basically sodium is neuro and potassium is heart. You guys, you guys did this, we already talked about not adding K, but you guys did this with NIPS. So you did this yesterday. Refer to the NIPS videos in your math resources in your course under Exam 1 if you need any review for this. It's pretty straightforward, right? This is the easiest of all your math. Now we're going to talk about those things that are threats to fluid balance. So the first one we're going to talk about is diarrhea. And we talk about diarrhea. It's super fun to talk about diarrhea, right? So the first, we talk about diarrhea because in developing countries, it is about 20% of all deaths because of those severe electrolyte imbalances. And we kind of brush it off like, oh, I had a little diarrhea, no big deal. But especially kids and elderly, they don't compensate as well. So when they get sick and they get diarrhea, they can crash hard. So diarrhea is defined as 3 or more loose stools per day. And it can be caused by an infectious process or an inflammatory process. It's spread via the fecal-oral route. And that is why kids get diarrhea a lot, because they like to scratch their butts, and then they like to play with a toy, and then they like to play that toy in their mouth. And yes, you all have touched something that some kid has scratched their butt with, so I hate to tell you. Yeah. There are other risk factors like contaminated water or crowded living spaces, poor living conditions. Those can all increase the risk of developing diarrhea. We're going to talk about acute and chronic diarrhea. Acute is not infectious. And as you can see, like I said, as we move forward and we do lectures, I'm always going to be using the same colors. Green is always going to be for clinical manifestations. Etiology is always going to be in pink. So clinical manifestations is just that it's an increase in frequency, that 3 or more loose stools per day, and it's a change in the consistency. It's looser. It can be anywhere from just being a little loose to pure water. And there's lots of things that cause it. A cold can cause it. They're, swallowing a lot of mucus, and it causes a change in their bowels. Different foods can cause, like something just doesn't agree with you. We've all been to that restaurant, and we're like, oh, got to get home, right? Stress. I know all of you have had that, if you run races, you have to have like that pre-race poo because you're all stressed out, or like sometimes you guys, like right before the exam, you're all in there like, please just let me go to the bathroom, I'm so stressed out, right? Like we need to play loud music in the bathrooms, I think. It's so quiet in there. But stress can definitely cause, there's different disease processes that can cause, antibiotics can cause diarrhea. And it can be self-induced. We're going to talk about anorexia and bulimia later on. And bulimics often use laxatives as a way of part of their binging and purging. So lots of different things can cause an acute diarrhea. And for the most part, they are self-limiting. They're done within 14 days. We don't do a whole lot except for make sure that they stay well hydrated during it. Now, of course, we're going to find out what the cause is, and if the cause is a certain food, then we can stop that food, or if it's, because we're using laxatives, we can stop the laxatives. Some of it, like stress, once the stress is removed, then the diarrhea stops, so you'll move on. But you don't really have to do a whole lot, but make sure they stay well hydrated during that time. Acute infectious is an actual gastroenteritis. So itis at the end means inflammation, right? So there's inflammation going on. It can be very mild or, progress along the way to severe. And basically it's caused by some kind of virus, a bacteria, or a parasitic. And we talk a lot about rotavirus in pediatrics because it's one of the biggest causes of dehydration in young children. And those who have children, did your child ever have rotavirus? So rotavirus went through my house. There is a vaccine for it. It has come and gone off the market as they tweak it, but rotavirus is awful. All right, it went through my family. My daughter got it from a friend. It causes the most foul diarrhea, like smelling diarrhea you've ever can imagine, and you have massive amounts of diarrhea and massive vomiting. So my daughter got it, and then me and my husband got it at about the same time. And my husband, being the strong man that he is, went to the bedroom and hid for 2 days while he was sick. No, he really is wonderful. But yeah, he did not deal with it well. I didn't see him for 2 days, and I had it, and it was horrible. I mean, if you need some kind of birth control, imagine holding your baby who you are so sick that you can't even get a diaper on them fast enough, as you're over a toilet puking your brains out and your baby's just pooping all down you because you are just, and I mean, it is just massive liquid poop and tons of it, like 20 diapers a day. It is a ton. So it obviously they get dehydrated really fast. Yeah, if that's not a visual, I don't know what is. But it was horrible. I could remember just laying on the couch and like holding a bucket and like trying to rehydrate my daughter because I nursed her at the time. So I pumped breast milk for her, which I barely had any because I was so dehydrated. And I had to take a little syringe, and like every 5 minutes I was giving her 5 cc's just to try to keep her hydrated because it was bad. It was also her first birthday, so we had all this family in town, and it went through everybody. So we gave that nice present to everybody for her first birthday. It is a memory we will not soon forget. But so it is awful. And that's why one of the reasons you need to make sure you contain it, because it just spreads so easily. When we talk about these viral and bacterial infections, they spread fast. So if you suspect it, the first thing you need to do is isolate them. We treat it based on the cause. We are obviously going to treat the dehydration. We're going to do contact precautions because we want to stop that spread. And just like I said, making sure they stay really hydrated. So that's acute. And then chronic, it's going to go to treatment, I'm sorry. Again, treat the cause, give fluids, oral rehydration solution. So that's the ORS. So that's something like Pedialyte or breast milk. We've kind of already talked about that. Pedialyte is not always the greatest tasting. So we try to give them something that they're going to drink. And you give it to them in any form they want. If they want it in a cup or a straw or a sippy cup or in a little dropper, whatever way they'll take it. Just be really careful that they don't gulp it, because if they gulp it, their stomach will spasm and they'll just throw everything up. They're thirsty. They've been throwing up, they've had diarrhea, they feel thirsty. So they're like guzzling it. And then as soon as they guzzle it all, then they go and throw it all back up. So you don't want that because it's going to make it worse. So just make sure that it's, small frequently. So 5 cc's every 5 minutes is what they recommend. We don't recommend anti-diarrheals if it's diarrhea. If they're throwing up, we can give an antiemetic. We want to stop the vomiting. But if they have an infectious process, the reason they have diarrhea is because the body is trying to get rid of that bacteria or get rid of that virus. So if you give them an anti-diarrheal, they're just going to keep that infectious process in their belly. They're not going to get rid of it. So we don't treat with any anti-diarrheals. Make sure you do good skin care, especially if it is diarrhea, because it can be very acidic. You want to change the diaper as soon as possible so it doesn't sit on the skin. And a lot of times we tell the parents not to wipe, because you're changing diapers so frequently. The more you wipe, the more friction there is, the more easily the skin's going to break down. So we tell them to get a squirt bottle and just squirt their bottom down and pat it dry so that we don't cause any more breakdown. You can do things. There's all those expensive lotions and diaper paste. Quite honestly, buy some Quaker oatmeal, just the cheap Quaker oatmeal plain, and make a paste with it. And you can put that oatmeal paste on their bottom, and it is awesome. We use it all the time with wound care. Yeah, we use it all the time in pediatrics, and it works great. It's cheap, and parents can afford it, because remember, we got to think outside the box sometimes, right? When we say go buy Aquaphor, you know how much Aquaphor is? It's like $20 a bottle. So I don't got that money. I love my job, but they don't pay me that well. So, but oatmeal is like $1.79, right? And it lasts a long time. So we've got to get creative and help them, because we don't want them to get a secondary infection. Again, we're going to avoid caffeine and sodas, because that's going to increase their diarrhea. And we can reintroduce a regular diet as soon as they're ready. I know a lot of people talk about the brat diet and this and that, but really, if they can tolerate it, we got rid of it. So if they can tolerate a regular diet, we just slowly start reintroducing their regular diet. Now we're going to talk about chronic. So chronic is something that's greater than 14 days. It typically tends to be some kind of chronic disease that's causing chronic diarrhea. So some kind of malabsorption issue, Maybe a chronic infection like C. diff is causing it. So it could be self-induced, like if someone with bulimia is using laxatives for a long time. But it's just an increase in the stool frequency and the water content. There's diagnostics that we can do, but basically, if they report they're having diarrhea, I don't know like how many diagnostics you want to get, unless you're really trying to find the cause. So like a stool sample can tell you if it's infectious or not. A colonoscopy can tell you if there's some kind of chronic disease going on. Yeah, history and physical. Always history and physical first. All right. The next is constipation. And I think we all know what constipation is. It's a decrease in the frequency of the stools. So not having a stool in 3 days. And we talk about it here. Oh, also painful bowel movement and a passage of a hard, firm stool. So there are lots of things that can cause it. We talk about it here because of mostly the psychological with kids, but they can have disease processes that cause it, electrolyte imbalances, environmental changes. Florida is hot and humid. And if you are used to living in like North Dakota where it's cool air and you move down here, maybe you're not used to drinking as much water because you don't need to up there. But down here you do. And so they have decreased water intake because of it. Drugs. We all know narcotics cause constipation, but I think a lot of times we forget, especially in Florida, where a lot of people are using antihistamines because there's always some kind of allergy season happening, right? It doesn't matter what season we're in, there's some kind of allergies. And we just pass out antihistamines like they're candy. They're over the counter and they just take them. What do antihistamines do? Dry you up. And so if you're not compensating by increasing your fluid intake, it can cause constipation. Because remember, as the stool is going through the small and large intestine and it gets to the colon to be, to make its exit, it sits in that colon and water gets drawn out. All right. And if too much water gets drawn out, it gets really hard and it can't pass through. With kids, the psychological disorder is called engoparesis. All right. So we talk about kids, and this typically happens, they've already been potty trained, and they can, when your colon starts to fill up, it has nerve endings in there, and you get that feeling like, oh, there's something in there, gotta go. All right. Well, kids get that feeling, and they're like, gotta go, but I am playing this game right now, and I am not stopping because I'm having too much fun. And so they ignore that sensation because I'm having fun. Oh my God, I gotta poo now. Right? So then they go and they finally can't hold it anymore. And they go and they have this massive poo, like the size of their head type poo. And that hurts like a mother, right? They just birthed the poop baby. And they're like, I am never doing that again. That was horrible. So they're like, never doing that again. I'm going to hold it. So then this cycle starts because then they're like, not going to poo, not going to poo, not going to poo. And then eventually you got to poo and another poop baby comes out. Right? And then they're like, never doing that again. So they just keep with this cycle. And eventually it gets to the point where it stretches the colon out so much that the nerve endings are stretched out and they can't feel it. So they can't feel that they have to go to the bathroom. And stool that's not formed yet starts leaking around the impaction, and then they start having accidents. A lot of times that's what they'll come in and they'll either complain of abdominal pain or they'll say, my 5-year-old was potty trained and now all of a sudden they have accidents in their pants. And it's because they have this big, hard stool blocking. So it's very, very common. Kids complain of abdominal pain all the time. 80% of abdominal pain is because of constipation. So I think we blow it off a lot, but it's very, very common. So we treat it with diet. We high fiber. We like to tell them to eat raw fruits with fruits that have the skin on them, like pears and apples. They are really good because they are good fiber. Bran is good fiber, so we want to increase that fiber, increase their water intake. Sometimes we have to give them motility drugs like Reglan to help them go. If it's a true encoparesis, what they'll do is they will clean them out. So they'll give them something like mag citrate. Has anyone ever taken mag citrate? Oh, I think there's a YouTube video of a guy taking mag citrate. It is honestly hysterical. But because it clears your entire body out. Like if you take mag citrate, if you ever have a bowel prep, make sure you are by a toilet. Do not take it without being near a toilet. It comes in a bottle, and it makes them go. So if you've been on a surgical floor or whatever, it makes them go. Warn your patient. Say, do not take this until you're home and ready to spend the day with the toilet, okay? So it clears them out completely. And then they often have to be on some kind of bowel regimen. It's not like we clean them out and we say, okay, have a great day. They have stretched their colon out to here. It is not like a rubber band where it just goes back. It takes some time for it to go back and for those nerve endings to come back for them to feel that they have to go. So they oftentimes get put on like drugs like Miralax that keep it soft, and they get put on bowel regimens like you have to sit on the toilet twice a day to go potty. Take that time.
What is that called again? I'm sorry.
The encoparesis. Encopresis. Huh? Yeah. They just, all right. No, not last, but fluid volume excess. I'm not going to spend a lot of time on this because you guys have had this in level 2. It is basically about like when heart failure happens. You've got too much fluid. We are kind of readdressing it here, just touching on it because it is part of that fluid and electrolyte. Just like we can have too little, we can also have too much. It's often caused because either we gave them too much fluid or because some disease process is retaining fluid, like heart failure. You guys know the signs and symptoms. They have waking, they have edema, they have crackles. We've already talked about all that. And diagnostically, basically, know what to check. Unlike when they were dehydrated, where the hematocrit was really high, here the hematocrit's going to be really low, right? Because, again, your hematocrit doesn't change. Your fluid has increased. So your hematocrit looks like it's lower, even though it's just because it's disproportionate because of the balance of it, right? So as long as you take some of that fluid off, your hematocrit will actually come up in theory, all right? Remember, if they're edematous, we need to check protein because if they have, if their albumin is high, they're going to be pulling fluid in third spacing. So we want to make sure that their albumin levels are appropriate so that they can pull fluid back into that intravascular space to pee it out. So if their albumin level is low, we would like to increase it because we're trying to pull the fluid in, right? Because we don't want them to third space. We can look at specific gravity, chest x-ray if they're sounding wet, we can look at it. And then again, it's assessment, we're treating the cause, checking vital signs, giving diuretics. So if it's a low albumin, we want to give albumin. It pulls the fluid into that intravascular space. We give the diuretic, they pee out that extra fluid. That's our goal. And then we're going to evaluate, is what we did effective? So anytime in nursing, it's important. This is why we do care plans the way we do them, is like, okay, this is my problem. My patient came in with such and such problem. So my diagnosis is that they have fluid overload, right? That's their problem. They've got too much fluid. And I know this because they've got crackles and they're, have bounding pulses and they have whatever. So, yeah, edema. So how do I know if my fluid overload is better? What happens to my bounding pulses? They go down. What happens to my edema? It goes away. What happens to my crackles? They go away. So sometimes I think you guys make it like really grandiose and really harder than you really need to focus on. Basically, your patient came in with a problem. If they came in with certain signs and symptoms, how do we know our treatment's effective? Those signs and symptoms go away, right? That's how we evaluate it. And then again, lastly, a quick review, acid-base imbalances. I always write it like this. I'm sure you guys have written it. pH 7.35 to 7.4, CO2, which is always related to your respiratory system, and CO3, which is bicarb, HCO3, I'm sorry, HCO3, bicarb. CO2 is always your acidic value. Bicarb is always your base value. Bicarb is always related to your metabolic system. CO2 is always related to your respiratory system. Everything for you guys, everything to the left is acidic. And that's why we flip those CO2 numbers, because the higher the CO2, the more acidic it is. And I would kind of memorize this little table and be able to brain dump it. Because always, if you know normal, you can figure out abnormal. If you know osmosis and how water falls, like water follows certain molecules, if you can brain dump that and know that, you can figure out any test question, okay? Eventually, you'll get to it where you know it like this. But right now, while you guys are novice nurses and still learning, get to know the normal. You can figure it out. It's much better than memorizing, all right? When you memorize and you're in a high-stress situation, you're going to forget everything. But if you know the normal, then you can figure it out. So when we're talking about anything acidic, you have a higher acid level and a lower base. If it's base, then it's higher base, lower acid. Pretty simple, right? We are obviously talking about metabolic here with fluid and electrolytes. So with a metabolic acidosis, I always think, I'm sure you've heard this, anything that comes out of my, yes, is acidotic, right? Anything, so if you have lots of diarrhea, because bicarb is lost in diarrhea. So if you lose that base, your acid goes up. So again, you have acid and you have base. If I lose base, my acid didn't really go up, but is it high technically? Yes, because I don't have that balance. I always have to have that homeostasis here. So for antacids, like if I drink or if I eat or drink too much acids, not antacids, if I drink too much acids, then my acid goes up. I'm higher, okay? So it can either be I get too much acid or I lose too much base. Either way, I'm at an imbalance, right? Okay. And treatment, basically we treat the cause, whatever's causing it. I think we've kind of beaten that one, right? And we give bicarb if it's the bicarb being too low, or even if the bicarb is normal but the acid's high, we can treat the cause, but while we're trying to bring that acid down, we can get bicarb to make it even again. We're trying to create that homeostasis. Metabolic alkalosis is anything that comes up, okay? So we have an excessive intake of antacids like Tums. People who are addicted to Tums, like they have maybe an ulcer that's untreated, then they'll just sit there and take Tums and Tums and Tums. You're only supposed to have like 3 or 4 a day. I've seen people take like half a bottle a day. Yeah, they do. They are kind of yummy. I will give you that. Or they have a loss of acid. So base comes out the bottom, acid comes out the top. So when you lose acid from vomiting, and a lot of people think, oh, okay, it's alkalosis. Vomiting is alkalosis. But they forget about an NG tube. When we're having NG down, it is essentially the same thing. We are taking stuff out of the stomach, right? We're taking acid out of the stomach. So again, I have acid and I have base. If I lose acid, even though my base didn't increase, it's still high, correct? So I have an alkalosis right here. If I take too much base, my acid didn't change, but I'm high, so I'm still have an imbalance. Either way, I'm going to have too much base. So a lot of times we're going to give lactated ringers. It's got basically we can't give free water. We need a solution with some electrolytes to balance it out. Okay, and obviously treat the cause, stop what's happening, what's causing it. You guys have seen these. You know, I know you've seen these pictures. You're going to see them again in level 4. As you move on, you'll start to talk about when your body compensates for these. Not in level 3, but when you get to level 4. And then to review the symptoms, but basically acidosis is typically caused because of diarrhea. Alkalosis is vomiting and G-tubes. And you've got that imbalance. All right, I think that is it. Do you guys have